Hi, everyone. Thank you for joining us for the Kirby Institute seminar today. My name's Philip Keane, and I'd like to begin by acknowledging the traditional custodians of the land where we gather today and pay my respects to elders past and present. Today, we're meeting on the lands of the Bidjigal people from the Eora Nation, and I extend my respect to Aboriginal and Torres Strait Islander people joining us here today and in the audience online. Just some housekeeping to start off with. The format today, this is a longer than normal seminar session because we have three presenters. We're lucky to have three guests from the United States. We're going to run a format where first Donaldson Conserve, who is online, is going to present, followed by Lisa and Ryan, who are in the room with us today. If you're joining online today, there is a Q&A box down at the bottom of the screen. If you would like to ask any questions, please enter your question there. And when we get to questions, I'll read them out. And for people in the room, there's a microphone over on that side of the room. We're going to start with Donaldson Conserve first, and we'll do some questions after Donaldson presents, and then we'll go to Lisa and Ryan. So Donaldson is an associate professor in the Department of Prevention and Community Health at the Milken Institute School of Public Health at the George Washington University, and is also the associate director of the Gil Lebovic Center for Community Health in the Caribbean and Latin America. Please help me welcome Donaldson.
Thank you very much, Philip, for the introduction. It's a pleasure to have the opportunity to share a little bit about a project that we are working on in the Washington, D.C. area. Let me just start sharing my slide. I believe it's a good afternoon for you all in that time zone. The title of my talk is Developing a Community-Based HIV Pre-Exposure Prophylaxis Service Delivery Intervention for Black Adults in the Washington District of Columbia. And I'm hoping to share some very limited initial findings based on the interviews that we've conducted so far. I'd like to start with acknowledging the team members, including Dr. Deanna Kerrigan, who is one of the co-investigators here in the department where I work. And then we have the co-investigators and as well as two other principal investigators at two other organizations. One is Population Council, which is an international NGO that works in many countries, including Tanzania, where I'll be talking a little bit about later. And then we have Us Helping Us, which is the community-based organization in Washington, D.C. that has been very crucial in helping us to make connections with other community-based organizations in Washington, D.C., as well as other trying to also recruit clients for the project. And I'd just like to highlight the fact that for the grant application, we had to have a community-based partner. It was actually a requirement for the proposal, and in the case of myself and also my co-principal investigator, Dr. Wei Martin, this was very crucial for us because most of our work had been conducted in Tanzania, so we were very unfamiliar with the DC area, and have been, it's been very beneficial to have a community partner at Us Helping Us, being led by Dr. DeMark Hickson. And I'd like to acknowledge the research assistants that have made most of the work possible for this project, starting with Samuel, who is actually on the Zoom now, and the other students, including a mix of master's level students and undergraduate students who have been very helpful. And then also to acknowledge the funding for this project, which would not be possible without this funding. In the US, we have a different Center for AIDS Research that are funded by the NIH, and all of these centers every year have an opportunity to apply for ending the HIV epidemic supplements that started in 2019, and this is the funding for this project. So just a brief background, assuming all of you are familiar with PrEP, of course, it's a daily medication or daily pill. And of course, now we have injectable PrEP that allows individuals to have the opportunity to not have to take it daily, but its objective is to help prevent new HIV infections among different groups, such as sexually active men who have sex with men, heterosexually sexually active men and women, as well as other groups that are considered to be at high risk of HIV. In the United States, as I mentioned earlier, there was an initiative called Ending the HIV Epidemic that was launched in 2019 with the goal of reducing HIV infections in the US, specifically, given that the PEPFAR initiative that was started many years ago focused more on other countries. The Ending the HIV Epidemic allowed more funding to support US-based research as well as programs to help reduce HIV infections by 75% in 2025, and then by 90% in 2030. And the initiative has 4 pillars, which are the diagnose, treat, prevent, and respond. And this proposal was, we had to identify which pillar our project would focus on, and we are focusing on the prevention pillar of the EHE initiative. Maybe similarly in other places, however, even though PrEP has been shown to work with strong evidence from different trials, there has been a very low uptake, or at least not the goal that we have has been met in many settings, including here in Washington, D.C., where it is estimated that in order to prevent new HIV infections, 14,000 individuals would need to be on PrEP in the Washington, D.C. area, but only 1/3 of this estimate is actually using PrEP. And this data probably also is not capturing what additional individuals we would need to have to start on PrEP in order to prevent more HIV infections. And some of the reasons for the low uptake of PrEP include transport and stigma in the community, but there are some interventions that have been conducted in other settings that have shown when community-based strategies are implemented, as you could imagine, they are more likely to help initiate individuals on HIV medication, or more recently for PrEP in low-resource countries, including in Ghana and Tanzania, where at least our team has more experience with this model. However, community-based service delivery, besides HIV testing in the United States, has not really been expanded to include HIV medication initiation or PrEP initiation. So most of the individuals who are tested at community sites have to be referred to a health facility where they can then have the confirmatory testing done and then eventually initiate ART or PrEP. Whereas in other countries, there have been more evidence and also more push to actually make community-based service delivery of ART and PrEP to be the standard of care, allowing individuals to not have to actually be referred to a health facility. And in order for us to leverage the evidence from these other countries, for the United States specifically, where there has also been funding designed to actually support the adaptation of interventions that have been shown to work in other countries for the US context, we need to have more more support to actually adapt these interventions, and then that could eventually help to support policy change. So as part of these efforts, the objectives for this project are to adapt a community-based intervention that was evaluated in Tanzania for female sex workers, and that allowed female sex workers to receive HIV treatment in the community as opposed to having to go to the health facility. This paper here is the main paper that showed the findings comparing the intervention arm between the comparison arm, which showed that the intervention arm, as you could expect, was more likely to initiate HIV treatment and also stay on adherent on HIV treatment 6 months following and being enrolled in the intervention group compared to the comparison group. So based on at least this study, we were able then to submit a proposal stating that we have experience with implementing such a project in another setting, and we would want to adapt it for PrEP. And one of the reasons we chose not to adapt it for HIV treatment, because in the Washington, D.C. area, at least, HIV treatment initiation and adherence is not as big of an issue in terms of the rates of individuals who are on treatment. It's more of the PrEP. So for that reason, we decided that we would focus on PrEP instead of adapting it just for HIV treatment. And this on the right is just a picture of a female sex worker collecting her HIV treatment from a nurse in Tanzania as part of the project, and some other information that covers the study. So after adapting this intervention, we are hoping to assess its acceptability, feasibility, and appropriateness in the DC area, starting later on this year, and then continuing on next year. So some of the core components, just to show what we are hoping to adapt, that we, in Tanzania, the service was delivered at either mobile tents or rented rooms, or even a peer educator who is a female sex worker, but who has a home where other female sex workers could go to receive the service, as well as the timing and the providers that were part of this intervention include nurses and clinicians and peer education. And as I shared, the focus was on linkage to ART with same-day enrollment, meaning if someone tested for HIV and they were HIV positive, then they didn't have to be referred to a clinic. They didn't have to wait and come back. Everything was done on the spot for them to receive the first month of HIV treatment. And in the DC area, we have not necessarily decided on when and where the services would be provided in the community for PrEP, and also what would be the legal procedures that we have to follow, because currently there is a policy in Washington, D.C. that does not allow community-based PrEP initiation. So we would need to find out how best to actually carry this out in this context to make sure that we are not violating any kind of laws at this point, and then how best to also conduct the follow-up strategies that would be needed. We are using the adapted model to inform the adaptation process for the intervention, and the adapted model has 7 steps, including the assessment phase, where we are, at least in our case, conducting a formative qualitative research method to inform our understanding of the target population, but also of the new context that we are working in, and then using that to inform the decisions that we will make for the adaptation, and then eventually following on these other steps to help produce the prototype of an intervention, and then eventually following to the next steps of sharing this with other experts in the area, and then integrating that in a pilot intervention so that we can then roll it out and do a pilot test. We are also using the consolidated framework for implementation research to help guide the questions that we are asking the different groups that we are interviewing for the assessment phase of this project. And briefly, the CFIR is a very well-known framework that has been used to inform a lot of implementation science research to assess factors related to these different constructs that are relevant when either adapting an intervention or trying to scale up an intervention that has been shown to work. In the group that we are interviewing, or we have been interviewing so far for the assessment phase, include staff members from community-based organizations that have experience with providing community-based HIV testing in the Washington, D.C. area, since that would be a natural platform for us to kind of learn from and also explore the possibility of adding PrEP initiation to the services, as well as PrEP providers, clinical and non-clinical, and also working with the Department of Health that are in the area, including the Washington, D.C. and the Prince George County Department of Health, which is in the Maryland state next to D.C., but also is close enough and also has a high enough HIV infection rate that we are also working with those 2 Department of Health so that we can pilot the intervention in both of these sites. And just to share, both of these, I guess, locations are also considered sites for the Ending the HIV Epidemic initiative. So once that initiative was launched, there were specific sites in the US that were selected as focus areas. And that's also one of the reasons we are including the Department of Health in Prince George County. And then lastly, we have had some success, but not as much with recruiting current PrEP users, as well as, focusing on different subgroup of PrEP users, so we can have a variety of perspectives. And these are the target numbers that we have in this table. We are hoping to reach, but as of now, we haven't reached all of these individuals. And I just want to share a few simple questions, starting with, at least informed by the CFER, including what do you think are the advantages and disadvantages of community-based PrEP intervention, so that we could explore that for the different groups that we've interviewed. And then thinking about outer setting, the patient needs and resources. The question is, what barriers do you think the Black adult population would face in participating in such a program? And then lastly, how feasible do the participants think that it would be to implement such an intervention, given the complexity of it? So currently, we have been able to recruit 5 current PrEP users and 3 potential PrEP users. And then for the Department of Health staff members, we've been able to also recruit 3 of them. And we are still hoping to recruit more Department of Health staff, as well as PrEP users and potential PrEP users. But for the community-based organization staff members or the PrEP providers, we are somewhat confident that we may not need to interview more of those individuals. And now we are trying to focus on reaching more current PrEP users and potential PrEP users, with a focus on trying to also increase the number of heterosexual PrEP users or potential PrEP users that we include in the sample. So in the next few slides, I'm hoping to just share some quotes from the specific codes that we have started to analyze and prepare code summaries, just to kind of share what we are hearing from those interviews. And it's not in anything extensive, but perhaps it could share some of the information that we are collecting so far. So related to the design quality of the cbPrEP intervention, one participant shared that, so when you do community-based work, you have to have a community health workers or individuals who are familiar with the community that you talk to. So the advantage is you have someone who has either lived the lifestyle or is currently in that lifestyle and understands the individual that they are talking to. So for me, I feel like that's the best approach. And I think that when someone is talking to you that has a similar background, that understands where you are in life, it gives you a bit of, you have a certain level of empathy for those individuals. So, just to kind of summarize it, a lot of the individuals were talking about the fact that we need to have somebody, who is from the community, whether that is a community health worker or peer educator, for this adapted intervention, which is similar to what we had in Tanzania. And another participant shared, so I think my biggest tip would be to have people from the community that reflect the community that you're trying to serve. So for us, for example, our medical providers, we had a provider who is a Black man. They're no longer with our practice, they left, but we also had another provider that identified, as as someone from the community and is a Black woman. I think that's really important, because when we're trying to reach the community, we're trying to reach vulnerable populations, specifically Black people, I think we need to have Black providers as well for those service. And one potential PrEP user shared in regards to education that may be needed is that I think potential users would want to know, I think, time, like what is the time commitment for this? It's like, I guess, with the flu shot, you get it done one day and then you don't have to come back for the next year. But like PrEP is a little more involved. And so even having some type of calendar, people can have what you can say, if you start this day through the days of the year that you need to come back for testing, these are the days that you need to make sure you take your pill and set an appointment to get your injection. Again, going back to my thought on attention span, people want to know like how much of a part of their lifestyle is going to have to become for the benefits of it. And I think cost as well. And then one PrEP provider talked and related to the staffing that would be needed is that, but if you are seeing multiple individuals, you know, 1 or 2 more providers, we can draw our own blood as need be. So I would say probably a medical assistant, 1 or 2 medical assistants, somebody to get them in your computer system, somebody for the documentation. I would go back really quickly. I would add PrEP navigator to your van. And then a current PrEP user mentioned in terms of potential incentives that may be needed. In some of those settings, offering an incentive, you know, could be a really good thing. If you have if you and your friend get on it, get on for it, we will pay your entry into the club, you know, that night. It could be so many different things, but with the incentives, as it makes sense to each of those different places. And one potential advantage that a current PrEP user shared was that the community-based PrEP intervention would be more targeted, whereas like at a hospital or clinic, you can go for anything, everything, but like, you know, what you're coming here for, so we don't have to like do a whole bunch of other forms and, you know, take longer. Coming for this one thing, just for 1 or 2 things, bada ding, bada boom, in and out, versus like a hospital or clinic. Just for the sake of time, I'll just jump to the conclusion, which is that, you know, I think based on the information we have received so far, we believe that there is a strong potential for us to actually be able to pilot this intervention in the Washington, D.C. area, giving, you know, first of all, the evidence that we know this works in other settings. And it's just that there's a limited evidence here in the United States. And we're hoping that, you know, this project would be one of the first to at least contribute to that evidence here in the United States. Using the adapted and the CFER framework have been very helpful for us to think about the kind of questions we should be asking the different groups that we are working with, as well as even the providers and also the current PrEP users, who are the 2 key, I think, groups that we need to be mindful of, because we will need providers to help with carrying out the intervention. So thinking about the staffing and time issues and compensation for them, but also then how to make sure that we are reaching the clients of interest that we would want to have in the community. So for the next steps of this project, we're hoping to complete the coding summaries of the intervention design codes by the end of August, at least. We are preparing to kind of wrap up recruitment so that we can finalize the coding summaries for this intervention. And then we are planning to do an intervention development workshop in September, where we will invite individuals from the Department of Health, as well as potential PrEP users and current PrEP users, if we are able to have them at that stage. But if not, then we will then develop that intervention protocol and share it by email, and maybe have Zoom sessions where we can obtain some additional feedback from different groups before we can then pilot the intervention in the Washington, D.C. and Prince George County area. Thank you very much, and I'm happy to take any questions.
Well, thank you very much, Donaldson. That was really interesting. It reminded me of a presentation I saw last week at the IAS Conference, where there was a presentation about community-based PrEP provision, and it was from Zambia, and a project among sex workers, female sex workers, where the annual HIV incidence was 47%. Like, I don't think I've ever heard of an incidence level that high. And PrEP uptake had been 21% among female sex workers in that area. But after the introduction of a community, a peer project to promote PrEP, PrEP uptake went up to 91%. So I think that really shows the power of peer experience and approaches. But does anyone have any questions in the room for Donaldson? We have one coming.
Yes, I can hear you now.
Great, fantastic. So Andrew Grulich is my name. So your presentation really reminded me a lot of the issues that we face here with scaling up PrEP. And we have the same situation. We have community-based testing centres which do a lot of testing but can't do PrEP because PrEP still requires a prescription from a doctor, and these places are not run by doctors. They're generally run by peers, sometimes with some peer nurses. So I'm wondering, are you going to hit the same problem with your centres that you would like nurses or peers to be able to be giving out PrEP, but medical regulation will require you to have a doctor on site?
Thank you very much for your question. I believe we will have to deal with the same issues, because even before we wrote the proposal for this project, one of the clinicians who work in the area as a PrEP provider mentioned that this would be impossible to actually do in Washington, D.C. because of the regulations in the United States that would prevent it. But thankfully, we were able to receive the funding, and now we are just learning how best to navigate those potential barriers so that we can actually implement the project. And we do have the support of the Department of Health in the Washington, D.C. area. So I believe with their support, we would probably be able to find out the best way to maybe implement or pilot this in a way that makes sense without violating any regulations. But we do, as of now, plan to have a provider in the site because of the regulations.
Thanks.
I had one question myself, Donald, and I guess that is just around once people have been started on PrEP through the program, how do you envisage that you will support people continuing on PrEP?
Thank you. So based on what the evidence was in Tanzania, the individuals who were started on ART continued on ART for at least 2 to 3 months before the provider helps to help make that transition. So part of that transition included initially visiting the healthcare facility with the client before they actually have to start going there, introducing them to the provider, the team that would then be able to assist them, and then also having the peer educator. So we are hoping to partner with an organization that would first go into the community to provide that community-based provision. But if the individuals end up staying on PrEP for that long, for that transition, that same team would be able to help with that transition to that community-based organization called Us Helping Us, because they also provide PrEP on site. So it would be, it would kind of help make that transition a bit smoother.
Okay. Well, look, thank you. I don't think we have any questions online. So if there are no more questions in the room, we'd like to thank you, Donaldson, for presenting. And we understand it's late on the east coast of the States where you are now. So you're very welcome, of course, to stay for the rest of the seminar. But if you can't, we understand.
Thank you for having me.
Great, thank you. So I'd like to introduce Professor Lisa Eaton and Associate Professor Ryan Watson. Lisa and Ryan are going to present together, and we'll have questions following their presentations. But just a little about them. Lisa is from the University of Connecticut and is a social and behavioral health scholar who is primarily interested in social determinants of disease. Her work focuses on the multi-level impact of stigma on linkage access and retention to healthcare among diverse populations. Her most recent work has focused on how systematic changes in providing healthcare can impact and improve health and well-being. She's mainly interested in how one's environment creates barriers or facilitators to accessing healthcare and how these factors impact overall health outcomes. Ryan is also from the University of Connecticut and is an associate professor there. His research is focused on reducing health disparities among gender and minority youth and young adults. He's motivated by the urgent need to reduce inequities in health for these vulnerable populations. And he has focused his scholarship on sexual and gender minority youth and young adults, their relationships within family, school contexts, and their health experiences. So please join me in welcoming Lisa first.
So thank you all. I'm excited to be here. This is Ryan and I started at the IAS Conference, and then we went to University of Adelaide for a couple of days, and now we're here. So we're kind of at the tail end of our whirlwind journey of Australia, and it's been very lovely. So thank you for the hospitality. And thank you to Dr. Conserve, because I think a lot of the research, if you're still there, that you went over actually kind of like sets things up nicely for what I'm going to talk about today. So the title of my talk is Novel Approaches to Addressing Stigma as a Barrier to Healthcare Among Black Sexual Diverse Men. And first, I'd just like to start by acknowledging the thousands of participants who have volunteered for our studies, the different community-based organizations who we've worked with, who provide services to our participants, different policy-based organizations working to impact systemic change. Thank you to my collaborators and co-authors, of course. And then all of my research is funded by the National Institutes of Health. And I know that I've talked with a handful of people who've let me know they're very interested in stigma. So I'm not going to talk about all the different projects I have focused on stigma. I'm just going to talk about one, given the amount of time. But I'm happy to talk about any additional stigma projects that I'm working on or that you're working on. Okay. So a quick overview, which mirrors a bit of what Dr. Conserve mentioned. The data on HIV incidence and prevalence among Black sexual diverse men is the first topic. And then I'm going to talk a little bit about different stigma-related considerations. And then I'm going to tell you about one intervention and maybe a little bit about another intervention that primarily focuses on addressing stigma as a barrier in mending the gap between individuals who are in need of healthcare and then being able to actually access healthcare. And then just a quick note on future plans. Okay, so all of our work is, we conduct our work throughout the southeastern US, primarily in the state of Georgia, primarily in the city of Atlanta. And over the years, what we found and what sometimes people are surprised to learn is that we have quite high rates of HIV transmission, in particular among individuals who identify as Black African American and individuals who identify as sexual orientation diverse. Quite consistently across different studies, we see about 35% of our participants reporting living with HIV. And then in our longitudinal studies looking at annual HIV incidence, we observe it at about 5%, which is quite high. If you're familiar with HIV epidemiology, if you're not, just be aware that that's very concerning. And then in our studies where we're looking at individuals who are age 40 or over among individuals who identify as Black African American and sexual orientation diverse, about 60% of them will report living with HIV. And again, this is throughout the southeastern US. So that's one of the reasons why I focused my area of work for so long in this particular area. So what exactly is going on? And we could have a long conversation regarding exactly what is going on, but there are a lot of different things to consider. But one area that I'm particularly interested in is looking at stigma as a barrier to accessing healthcare and stigma as an ongoing driver of health inequities. So just a quick note on what exactly is stigma. So stigma is, I mean, you can see this in the literature starting in about the 1960s. It's an attribute that's deeply discredited by society and results in rejection. The other thing that we have consistently observed is that all societies will stigmatize some conditions and some behaviors because doing so provides for group solidarity by delineating out groups from in groups. So by training, I'm a social psychologist, so this speaks very near and dear to my heart. So I've applied my work as a social psychologist to HIV epidemiology and HIV transmission. And creating in groups and out groups is a form of survival. And so in order to do that, you create hierarchies. And one process that perpetuates hierarchies is stigmatizing, or is the process of stigma. So, so in stigmatizing an individual, you label somebody, you associate that label with a stereotype, you disconnect that individual from the in-group, that results in status loss, and then that kind of justifies discrimination. Now that's like many decades of stigma research summarized very quickly. But that's it in a nutshell. So stigma can be somewhat overwhelming to process kind of like efficiently in how we would go about navigating stigma and addressing stigma within the context of interventions to impact HIV transmission. So one of the models that I've worked with quite a bit is the HIV stigma framework that I've adapted from my good colleague, Val Earnshaw. This has kind of like been the most straightforward way for me to conceptualize this. So the idea is that we have drivers of stigma, and those are stereotypes, which are group-based beliefs about individuals who have been stigmatized, and prejudice, which is negative emotions, and discrimination, which is the expression of prejudice and stereotypes. These are the societal level drivers of stigma. And then these drivers affect the mechanisms, which are the actual experiences of stigma among individuals, one of which being internalized stigma. So internalizing negative beliefs about the attribute. Enacted stigma, which is actually essentially experiencing discrimination, and anticipation of stigma. How does, in particular in the context of accessing HIV transmission care or HIV prevention care, do you not want to seek out help from a provider because you're worried about how that provider will treat you? That's an example of anticipated HIV stigma conceptualized within this model. And the resultant health outcomes that come from these different drivers and stigmas. So I have used this approach to help in establishing various interventions in my work. One thing, though, that I do like to say when you're kind of trying to take on the area of stigma is that it's omnipresent and it can feel a bit overwhelming. And so when I'm mentoring individuals around this topic, when I'm working with graduate students, I just say, look at like, all we can do is one small piece at a time. Like stigma is quite overwhelming. It's very hard to change human behavior. It's hard to change structural systems. It's hard to change society. And so we're just going to do one small piece at a time. So I don't have the answer to all HIV stigma related issues. I'm just doing one small piece. I'm just doing what I can, but I do believe in the collective good of addressing stigma as a barrier and the potential impact it can have on HIV transmission and HIV prevention sciences. Okay. So another piece to consider that I think is very important in developing stigma interventions is really considering the level that you're interested in intervening on. So the way that I conceptualize the level of intervention tends to come down to one of four areas. Is it a public policy that you're looking to affect? So of course, like something like HIV criminalization laws can have a big impact on stigma and beliefs around stigma within the US. I mean, we still have laws on the book that HIV transmission is illegal. And although it's unlikely to see those laws play out in our court systems, they do actually do. I mean, people have, it's a criminal offense. Community and structural interventions. So what can you do to impact different community environments to say make them more or less or more appealing and less stigmatizing for individuals to access? What is it about the built environment that could impact people's experiences of stigma? Social and sexual networks, you might be familiar with like popular opinion leader interventions where you basically assign individuals who have, well, I'm not exactly describing it accurately, but the most recent interpretation that I've been involved in, assigning individuals that have a certain like high level of status within a network to basically permeate out like anti-stigmatizing stereotypes and prejudice. So working against those stereotypes and prejudice. And then on an individual level, how do you interact with an individual to help them like cope and work through stigmatizing experiences? Just doing a quick time check. Okay, I think we're in good shape. Okay, so I'm going to tell you about one intervention that we finished not too long ago that we have been annualizing, and then I'll tell you a little bit about how that intervention has led into another intervention. So this particular project is called Project Link, and Project Link, we recruited 400 individuals who identify as Black and sexual orientation diverse around the Atlanta metro area. in the US. And what we did was a 2x2 factorial design. So there were two levels each of 2 interventions. So what we did is we randomized individuals to either receive stigma-focused counseling or a time content matched health information control. And then we assigned them to either receive their HIV testing appointments online. So we mailed everyone an HIV and STI test package, and we set up a video chat appointment where we would walk individuals through self-administration of an HIV test, and they could get the results there. Or in-person tests. So the idea was that we could, there was like an individual level intervention where we focused on stigma. And then there was a structural level intervention where we focused on changing the built environment where people would be able to access their HIV STI tests. And I do this every time. I explain it and then I realize I have slides later that explain what I just said. So anyways, there's a structural focused environment. I do want to say a couple things about this before I switch slides. In our formative work, what we had realized is that we had many participants who would just say things like, I don't want to go to a test site to learn my results. Like, it's not necessarily about not wanting to learn the results. They're concerned about how they might be treated there. And they're concerned about things like, what if they learn they're living with HIV and they want to leave and they can't? Or like, how will the counselor respond to their results? So there were different factors, and we thought, well, we can actually modify that. Like, what if you felt like more in control because you were able to sit in your bedroom? The counseling for the stigma-focused counseling, there were 4 main areas of focus. One was assessing and discussing factors known to be drivers of HIV stigma. The other was evaluating concerns around testing. The other was discussing prior instances of stigma. And the other one was promoting resilience beliefs and positive adaptation. One thing that we really tried to do in our stigma-focused counseling is develop a sense of healthcare agency. So it's a client-centered approach to counseling that's based on motivational interviewing. What we have found in our formative work is that some individuals are just naturally really adept at advocating for themselves, and they really don't care what the blockade is in the way. They will just find ways around it. Whereas other individuals, they face a barrier and they're like, no, like they regress back. And so a lot of the counseling was focused on what we call healthcare access agency, instilling that, no, I'm going to keep moving forward. I'm going to focus on like the care I need, the treatment I need, and less on how I'm being treated. And I've argued with people back and forth about like the validity of doing individual focused interventions and putting that burden on the participant, and we can have that conversation. But again, that's when I say, okay, we're doing one small piece of a really monstrous problem. Okay, so we had like mostly positive outcomes, but a little bit mixed. So okay, and I should back up and say this. We followed individuals over a 12-month time period. So what I'm showing you are the outcomes from basically 3-month, 6-month, and 12 months after the intervention or after the randomization to the arms. And what we see is a fairly, and I'm reporting things on the aggregate, so I don't report it just because of time, I don't report it by month. So on the aggregate, we see fairly high rates of showing to the HIV testing appointments, but we do see a significantly higher, 86% versus 75% of individuals who were offered the appointments at home. They were significantly more likely to uptake those appointments if they could do those appointments from their house. And I should say that they mostly were done from their house. It was very common to see someone in their bedroom or in their kitchen. Vast majority of the time, that's where they are taking these appointments. Okay, now we did not see a main effect of the counseling on HIV testing appointment uptake. What we did, though, observe was that for individuals under the age of 30, those who received the stigma-focused counseling were more likely to report current PrEP use. So there's kind of like an interesting twist there, right? Because ultimately, that's what we were hoping they would access. And the reality is that, so I have a research site and I do not work in a medical clinic. The advantage to that is that I have to access individuals who, for the most part, aren't in treatment. The disadvantage is I don't work in a medical clinic. So when someone wants to access PrEP, we work with them based on the insurance that they have, based on a multitude of factors to get them into long-term care. So though the main effect, we didn't see an impact of the main effect of counseling on HIV testing uptake, we do see it on individuals so they were going to a medical provider for PrEP access, and that increased among individuals in the stigma counseling session who were under the age of 30. And we also noted lower rates of depressive symptoms among individuals who received the stigma-focused counseling. So, and I'm working with clinicians now to kind of like dissect what exactly is going on there. The other thing that we found in the study that was interesting that is an important point to know is that individuals who were randomized to receive the testing appointments at home, they were more likely to test HIV positive. They were basically twice as likely to test HIV positive, or I should say screen positive for HIV, because these are screening tests, they're not confirmatory tests. And they were randomized. So in theory, we shouldn't see a different percentage of individuals testing positive. So it could be like a randomization artifact, or if I'm speculating a little bit, it could be that if an individual believes that they're living with HIV and that's predictive of testing positive, it could be that individuals were more comfortable learning that information from their home than going into an office and learning that information. But suffice to say that there's something going on there, because we see basically double the percentage. Let me just check where I am on time. Okay, and I'll say one other thing before I wrap up. So we also, as a result of the study, we did an additional stigma-focused intervention that was basically, we were interested in capitalizing on that PrEP-related finding. And so we provided in an additional intervention, we provided additional counseling support. So what we did is individuals got the intervention, another group got the intervention plus text messaging, another group got the intervention plus ongoing stigma-focused counseling. And what we found in that was a beneficial effect of providing additional counseling. As you increase the gradation of intervention level, the likelihood that individuals would report PrEP use increased as a result of the intervention. So we're working, and if I had more time, I'd show you those results, but I don't. But anyways, there's a lot of movement there, and that's part of our future plans as well. Okay, our fight isn't over. Thank you.
Water. All right. So yeah, as you heard, Lisa and I will take questions after. My talk will complement in a way, but also change gears a bit from Lisa's talk. Again, I'm Ryan Watson. For some context, I started as a grad student postdoc and early faculty member studying the health and well-being, health disparities of sexual and gender diverse adolescents and the relations with families and schools. And when I met Lisa at UConn, University of Connecticut, I applied for what we call a KO1 award, NIH, a career development award, and it was to shift that work into HIV prevention. So two things I want to say about today. One, I'm going to kind of share a newer method to our team that is a way to quantitatively assess intersectionality of multiple social positions. And so I'm going to show an example of HIV prevention behaviors among adolescents to make the illustration of using that model. And also I'm going to talk about a data set we just finished collecting. And I think it's exciting and maybe it'll be of interest to folks on the call or in this room, in particular, in a way to do maybe like cross-national comparisons of sexual gender diverse folks in the context of HIV prevention or other health behaviors between, for example, Australia and the United States. My slides are very text heavy and not as pretty as Lisa's, so please forgive me in advance. So there's a lot of info, but what this is mostly to say to a context of the measures I'm going to talk about in the context of the statistical method today. So although, as you very well know, in the Kirby Institute, HIV rates have lowered dramatically since the 80s, 90s, we still see quite a few adolescents in the United States testing positive for HIV every year in the United States, especially among 13 and 24-year-olds. There are three behaviors in particular we can focus on to reduce the rates of HIV. One are consistent and proper condom usage, regular HIV testing, and the use of PrEP, pre-exposure prophylaxis. However, the Center for Disease Control put out stats quite often that show we are at suboptimal levels of these behaviors among all people, including adolescents. Half of sexually active adolescents reported using condoms in the latest CDC surveys, and only 20% of high school students who have had sexual contact with same or both sex partners have report testing for HIV. Some examples of the suboptimal levels being reported. A couple of things we wanted to address in the existing literature with the presentation I'm sharing today. Though most of this work on HIV prevention focuses on men who have sex with men, who are and folks who are assigned at male at birth, particularly focus on gay and bisexual men. However, at the same time, a lot of the work I've done with my team in the past 5 years show there are emerging identities to pay attention to. So there's large numbers of kids in particular identifying as pansexual, non-binary, queer, some of these emerging labels, the ideas that aren't new themselves, but identities that may be missed by our campaigns for gay, bisexual men. Studies, especially in social sciences, that look at HIV prevention are looking at single social positions at once. So gay versus straight men, or Black African-American versus white men in particular, but oftentimes can't look at patterns or intersections of these social positions that might be meaningful. Oftentimes also, especially in surveillance data, we have so few numbers of, for example, pansexual trans women of color, where most researchers have to combine these diverse groups into, collapse them into single categories. However, the data we have today, we're able to look at more distinct intersections of social positions. Also, in studying intersectionality, we often have to look at regression models and 2, 3, 4-way interactions, which, as you probably know, are very hard to interpret, especially when they're diverse populations. And so I'm going to present on a model today that kind of has a different approach to looking at intersectionality. So today we're going to try to expand this, or I'm going to try to expand it to look at four outcomes in particular: consistent condom usage, HIV testing, PrEP awareness. So have the participants ever heard of PrEP, and have participants used PrEP? And I'm going to focus on 4 social positions in particular: sex, gender, sexual orientation, and race ethnicity. So the data, I want to spend a little bit of time talking about the data because it was one of the hardest things I've done, is collecting this data in my career so far. It was a challenge collecting online data in a day where fraud is rampant everywhere. And so I'm going to talk a bit about that process. We partnered with the Human Rights Campaign. It's the largest LGBTQ nonprofit in the United States. If you don't know of them, they have an equal sign bumper sticker if you've been to the States or seen their advertisements. 5 years ago, I partnered with them and we collected data from 17,000 youth. We didn't pay participants for completing the survey. So we had a small drawing. The chances were very low of winning. And this time we had a grant from NIH to pay participants to partake in the survey. And so I'm going to talk in a minute about how challenging it is to pay folks online that you probably already know. We spent a lot of money advertising on Meta, so mostly Instagram, Facebook. We found some influencers that were really helpful on TikTok. We tried to be creative. 5 years ago, we got 10,000 participants from Twitter. Kids are not on Twitter, or sorry, X, I guess we call it now. Twitter just changed their name, if you didn't know, to X. And kids are not on that space anymore. So we had to get creative to find where kids were to be able to employ our survey to them. We reached 1 million youth on Instagram Meta, and participants in the survey I'm going to show you today were 13 to 18 years of age. They all identified as LGBTQ, so there's no cis heterosexual participants in our data set, and they all lived in the United States. In the end, we sampled 17,578 participants. 3,000 of the 17,000 opted to receive incentive. So that's $5 we gave to Amazon. And I have this next slide that's a robot, because in my data collection before this project, we paid $15 to Black and Latino MSM who are interested in using PrEP. And like every colleague I know, we quickly were a victim of fraudulent responders. And so what I learned in a long process, and this sounds like a conspiracy theory, but there's this dark web I've been told by participants, like maybe like a Reddit, where folks will go on and post opportunities for other like scammers to take surveys. And so what I've learned is that, I mean, I think most people who haven't been doing online research recently think of bots or fraudulent folks as like going in and selecting one and getting a participant, you know, or getting a incentive. But what I've learned is that that's these scammers or fraudulent folks can write scripts to be able to take a survey that looks almost identical to what a real person would take the survey in 40 minutes, co-varying answers, knowing what the inclusion criteria is, putting the zip code in the US that would match the area code as your phone number. So almost impossible to be able to tell the difference between a real response and a fraudulent response. Grad students are becoming, in our program at least, victim to this all the time. So they'll get 500 responses in the matter of a day and think, wow, my recruitment efforts were so great. However, just little nuances that I've learned to pick up on, like Gmails that look real, but actually are systematically fraudulent. And I can talk about this after and after this seminar if you have questions in the ways we've learned how to detect these participants. The reason I'm going into all this is because what we decided as a research team was we were going to require kids to have school emails in order to be paid, which has a pros and cons. I mean, there are kids, of course, that are not in schools. There are kids that are in schools that don't have emails, though about 99% of United States schools provide email addresses to their students. And if a participant wanted to be paid but didn't have a school email, we would video chat with them, or they could send us their ID, or we would get creative. And very few people engaged in this opportunity. So we think our data is rigorous and not full of bots and fraudulent responders, we hope, but we did a lot of work based off of our previous experiences. So though we had 17,000 folks respond to the survey, which in most projects allows us to look at deep intersections, I guess you would say, or nuanced experiences of very diverse LGBTQ young people, this particular project I'm showing you today is among kids who are sexually active. And there were only about 3,000 of the 17,000 kids, because it goes down to 13 years old, of kids who reported being sexually active. So these are still pretty diverse, like out of like maybe epidemiological surveys where you might just see straight, gay, bisexual. We still in this study are using pretty diverse response options in these social positions: gay, lesbian, bisexual, pansexual, queer, asexual, questioning, something else. But in the survey, we asked more options than this, because we know there are more than just these options for sexual orientation and the other social positions. So you could just see here some of the ways we were able to operationalize these 4 social positions I'm going to talk about. Our measures, which you already saw, were condom use. 2,984 participants reported on this measure, as well as ever testing for HIV. This is a sexually active sample. The method I'm going to show you in a second works best with dichotomous outcomes. So for condom use, it was I always or I don't always use condoms when I'm sexually active. Testing for HIV is always, or I've ever tested for HIV versus I've never. Heard of PrEP, we use the full sample. 10,871 folks responded to, have you ever heard of what PrEP is? And then, of course, we have a very young sample, so very few people are on PrEP, but this was yes or no, I've ever taken PrEP. So this method's newer to me. I'm not an expert in it, but I know enough to be dangerous and explain it. So I'll hopefully explain it correctly. We have several papers published with it, so I can point you to those. But the idea of this is called exhaustive chain, chi-square automated interaction detection, a way our team is starting to better understand intersectionality in social science research. I'm going to show you a picture in a second, so you don't have to worry about digesting all of this, but just know it's a decision tree method that researchers are starting to use to study multiple intersecting social positions. So what it does is takes an outcome, for example, condom usage, and tries to understand what's the best categorical predictor that might explain the variance or differences in that outcome. And it'll split based off of, the model will split it based off of that next level of what's discerning the variability in the outcome. And it'll keep doing that until it's exhausted all options. That might not make any sense. So I'm going to show you this simple-ish tree. So if you were running a business and you wanted to to survey all your customers to know what they like and don't like about your business, you might put out a survey. In this case, 24.3% of participants responded to your customer satisfaction survey. And what the model will do is say, okay, among those 24% of folks, what characteristic of them, or social position in this case, best represents who took your survey? In this case, maybe it's rural versus urban. More folks who are living in urban areas are responding to your survey. Among urban areas, it might be that among people who live in urban areas, it's actually homeowners that are most likely to respond to your survey. In rural areas, the next case might be that it might be employment status, full-time, part-time, retired. And then among retired, it might be that there are folks who are older or younger. So if you have limited resources to try to get more people to take your survey, you might focus on rural folks who are retired and over age 65, because only 1.4% of those folks are taking your survey, which is much lower than the average of 24.3%. You can see you're doing a really good job at reaching homeowners who live in urban areas, so you might not want to focus on trying to reach those folks. So what our tree looks like when we look at those 4 separate outcomes is like this. Obviously, the point is not for you to look very closely here. What we do is in our team is take this tree and then digest it into a table and maybe look at patterns across outcomes to understand where's the nexus of social positions where we're not reaching folks for HIV prevention techniques, or we are doing a really good job. So this is what it might look like in a table where you look at these trees across identities. You could see that there's 4 outcomes. The very top is consistent condom usage, which is here, past 3 months. So 36% of our sample reported using condoms consistently in the past 3 months. The next outcome is ever tested for HIV. 15% of participants reported ever testing for HIV. Ever heard of PrEP? Ever taken PrEP? Since you could really go in and look at a lot of different patterns and try to understand what this means. I'm going to give 2 takeaways from what we think is important from these particular findings. One is that gay, lesbian, queer males rise to the top of a lot of these different outcomes, which is not surprising. A lot of our efforts in getting people connected to PrEP or testing for HIV is focused on, like I said in the beginning, gay, bisexual men. But in the 2017 study that I talked about, the predecessor to these data, there were 25% of the entire sample, so thousands of kids identified as pansexual, which was surprising to a lot of my colleagues because they had never heard the term. Yet but thousands of people in this non-probability data set identified as something that an identity that we're not really reaching in HIV prevention. Most of the messaging is for gay, bisexual men. So in the red, so I didn't describe this very well, but the green would be higher nodes, we call them, intersections of identities that have high levels, high prevalence of these outcomes. Red is lower than the average. So the average is 36% of using condoms consistently. 41% of folks who are bisexual and queer and pansexual are reported using condoms. However, the red bar is those who are lower. The red row is groups who are lower. The most nuanced outcome here is ever heard of PrEP. And so you can see here where this intersectionality approach is being applied. So folks who are male and gay, lesbian, and queer are more likely to have heard of PrEP. And then the folks who are less likely to hear of PrEP in the red row are folks who are pan, bi, asexual, questioning else. So that's one of the take-home messages I want to give to you today. I'm going to go to the next kind of big results slide so we can look at this. Another thing, sorry, I just switched up. I'm going to go back. Something that's interesting in these tables are there are no meaningful splits in the chain analyses by race and ethnicity. And I want to caution, I say that, and it could be due to statistical power. And so I don't want to say race, of course, doesn't matter in these prevention efforts. Lisa's dedicated her entire career to looking at Black and African-American men who have sex with men or sexual gender diverse folks. But in these, for these outcomes in this data, race was not an important differentiator for kids. We have done these shade analyses for other outcomes like depressive symptoms, family experiences, and race does rise to the level of being meaningful. And so we're trying to think through that. What does that mean? And how might we, and that's the bottom line here on this slide. And another thing, if you read through this, and it's a lot of text, would be, how can we start to think about repositioning or thinking about maybe remessaging HIV prevention campaigns or to go get tested for these emergingly diverse, is that a phrase, youth who are now identifying as gay, lesbian, or bisexual, and are using terms, labels that are very different. I think I'm probably a little over time, so I just will say that's it. And I'll share some references and say thank you. But I think Lisa and I are open for any kind of questions and discussion now. Thanks.
Well, thank you, Lisa and Ryan. I think, Lisa, you described stigma as omnipresent, persistent, and monstrous. And no, but I think that's entirely appropriate. And I guess it reminded me that, I think in this country, homosexuality, same-sex attraction used to be highly stigmatized, but I don't think, when I was a young gay man, I ever could have imagined how much that situation might have changed by today. So although there was an elephant then, and it is appropriate to be chipping away part by part, I think, that certainly there's hope, and work like yours shows how there can be successes. Do we have any questions in the room? Would you mind, Carolyn, going to the microphone?
On my way. Hi there. My
You might need to speak into
hi
it.
there. Yeah. So my question's for Lisa. Lisa, I'm a health economist, and I'm just doing a bit of a review currently on interventions which include costing as part of the related to stigma. And there's very few. And I just noticed that you had cost data analysis up there, and I was just wondering what you were costing and if you had any thoughts about how you can sort of get people to add costing as a consideration when they're doing some of these interventions, because I think it could be quite powerful if you want to go and scale up something or do something else.
Yeah, no, it's a great question, and I appreciate it. And I think it's always good to take the opportunity to say that they're quite cost efficient. So we do have a costing component of the intervention that I kind of briefly mentioned at the end, our project Jumpstart. But I think it's suffice to say, one, that I'm not a costing expert, so you have to forgive me for my comments. And two, so the way it's been explained to me is that seroconversion, even besides like the humanity component of it, but if we just take a purely costing perspective of it, that it's very expensive to treat people for a lifetime who are living with HIV. It's very expensive in the context of providing a single session intervention. And then in the case of the Project Jumpstart that I mentioned briefly, even when you provide people ongoing text messaging support, or in that study, we do monthly check-in calls. It's the cost of that, even to provide that among a large group of people, is very small compared to seroconversion. And so what we're doing right now is we're kind of working through the HIV, using different metrics to look at the HIV preventive effect of these interventions, and then modeling the cost of that. We also have a cost, and I'm not going to use the right word. It's not a cost, it's a cost, it's a societal impact cost, where we look at the cost to participants, which is also very, very small, particularly with the mobile delivery of these interventions. So it's in process, and the cost is quite low. Hopefully that helps.
I guess I'm sort of interested in the cost. If you had 12 months of data there, and if people don't attend, then there's those sorts of repercussions as opposed to attending. So it's also
So to
Think
put
of
like
that.
to do training and like provide an office and overhead and have people not, am I not interpreting that correct?
I guess I'm thinking more about the benefits to the people by, you gave the example of somebody mightn't attend a service. So I guess it's thinking about those repercussions for not attending as opposed to attending a service and being on PrEP.
Yeah, I mean, I think, and maybe we're not conceptualizing it correctly or fully, but I mean, I think we tend to conceptualize it as like if individuals aren't accessing HIV prevention services and then they do seroconvert, given how effective the behavioral and then in particular the biomedical prevention interventions we have, I see that as the cost. But are there other costs that you're considering as well that I'm not? Oh, well, we can also talk later too, because I really appreciate the work, and it is actually like aim 2 of this grant is the costing, and so and like I said, it's in process, and so I'm very curious to hear people's thoughts on it. And our costing expert took a job at the White House in the middle of the project, and so we had to get a new costing expert. So I've had to learn a lot and listen to multiple different approaches. So I'd be happy to learn more. Very happy to learn more.
And Carolyn, if you would like, Lisa and Ryan have generously agreed to stay for a little longer, and we're going to meet in room 675 for some further discussions afterwards. If you'd like to join to talk about that further. I had one question for you, Lisa. So you mentioned the result in terms of people who are randomized to test at home, and how a higher proportion of them had a reactive screening test. And that is very interesting. I wondered, I think you said that overall, 85% of people who were randomized to test at home went through with the intervention.
Yes, that's right. They tested. Yes.
And you'll have to answer up here. But so my question was, and you suggested that maybe people who have a belief that they may have acquired HIV might be more likely to go through with testing. And so I wondered whether you looked separately at what proportion of those people who tested positive took up the testing intervention compared to those who were negative.
So that was a really, really good review. I'm glad that came out clearly. So I think what could be the issue is I don't know. So all I know is the individuals who showed to either condition and what their test result is. So I don't know of individuals who are living with HIV, but who didn't test with us. So I think and hopefully I'm capturing what you're saying correctly. I think yes, it again.
Tested negative, was their uptake lower? Uptake of testing. Well, I guess you don't.
Maybe I'd have to look at that. I feel like, yeah. Okay, I do see what you're saying. Was there, I think I would just have to look at that more closely. And I think that that's one of actually my favorite parts of giving a talk, because it like gives me ideas for directions for future analyses. And I think what and kind of like getting back into it too, because we've looked at this a little while ago, but I think the other thing is kind of like digging further into the different risk perception measures that we have on here as well. I'd have to, honestly, I would just have to go back and look at the data more closely, but I think it's a really important question. And I think if I have additional data that kind of support this point of like, if you believe you're living with HIV, you're more likely to show for a home test, I think that could have a substantial impact on how we conceptualize the importance of the built environment, and could be quite persuasive in changing things. Yeah.
We don't have any questions online, so we do have quite a number of people online, but you're a very quiet group. We have a little bit of time. I had one question for Ryan, and the stuff you mentioned about fraudulent respondents, I think certainly is something that we're grappling with here. So I wondered if you could perhaps say a little bit more about the strategies you put in place to try to identify or counter that.
Yeah, so a question. I think that, so just to have more details of how we determined that they were fraudulent before, we had, I think the most common way we discovered was that, and this is happening to students, is folks we'll get a big influx of survey responses. We'll go to pay them. And I think what happened to us first is we had a suspicion that folks were fake. And this isn't really answering your question yet. I'm just telling you how we discovered it, but that kind of it led my thinking about what we did next. And when I had a suspicion that we had been fraudulent, like we had fraudulent responders, and I was going to pay out hundreds of dollars to them, I responded to participants and said, in order to be paid, and this is with like ethics board, this is what they told us to do, and this is their approval, I need you to reply back to me from the email that you took the survey with, because what I learned is folks were just getting a bunch of aliases on Gmail and then having their participant, it basically would just, all their incentives would come to one email. I wanted them to send unique emails from their emails with information that they gave during the survey process. And what I learned is the fraudulent scammers would save all of their responses that they gave on the surveys, and they were able to produce that, which I was very surprised about. But hundreds of emails came in, and they were all from the quirks of email responses were all the same. So for example, 20 or 30 email responses came with the reply email were in the same weird font and different colors, and had Mandarin characters in the response email in the very same way that was not plausible it could be from 20 different people. So I learned really quickly that just by having somebody reply to me, for example, with what they put would not make sense. I had participants write qualitative responses. So say what was your favorite childhood memory? And that wasn't enough. So I think what happened is these people that wrote the script knew that they can get $15 if they just wrote one sentence of a memory. But those, I think they were not first English language folks. And so their responses would be consistently erroneously wrong, or improbable and didn't make sense. So even putting qualitative things in there didn't make sense. So, I mean, what we just ended up doing was, we use Qualtrics, and do you use Qualtrics here? And you could put on the bot detection, you can track IP addresses. Those still aren't enough. From folks who I knew, I guess something that was interesting is I really did seem like it worked to use school emails for kids. I'm not sure the right answer for adults, but what we found out is that fraudulent folks could also get school emails from community colleges. So they could go there. We have hundreds of community colleges in the US where you could go and sign up for an account and get an email account from the community college. So it was a .edu. It was napavalley.edu. And we got 50 responses from Napa Valley, which was very unrealistic because we didn't advertise at Napa Valley. And I don't think there were probably 50 queer students it was a small community college. So what's funny is that Qualtrics didn't identify any of those as fraudulent, but I knew they were fraudulent because when I interacted with participants, I found out that we did all this investigation. We knew it was fraudulent. So I guess this is not really an answer, but what I'm learning is the survey softwares can't detect when these are fraudulent. IP addresses are very easy to spoof with VPNs, I think. And so this isn't an issue for Lisa because in her work, she verifies people's identities with ID. The participant shows their driver's license or some kind of identification, where if you want to collect information from 17,000, in our case, kids, and pay them, I don't think there's enough resources in any way to be able to figure out who they are. So our response was school emails. It was mostly all right. We were able to find some fraud. But even the old traditional ways a few years ago they call them honeypot items. So people would write scripts to take surveys, but a honeypot item is something that is not visible to, so you make logic for an item that if you were taking the survey, you could never see. It would say show this item if someone's response to age was 9,000. So what that means is there's a question in the back end of the survey that participants like us would never see. But when you write a script to take the survey, you would actually have an answer because you've hacked the back end of the survey. So there's even things like that they know that the fraudulent people know how to get around. So I think the answer is somebody needs to write like a guide, because this is happening to, as you know, I think that's the impetus for the question, is it's happening to everybody. So that was not an answer, but hopefully it's like gives you something to think about.
No, that's very useful. I think, yes, some sort of collaboration on ways to counter, well, recognize and counter this sort of thing would be fantastic. We have one question online, I think. And it's for you, Ryan. You mentioned that race was not significantly different across the gender and sexual identities. Do you think it relates to the survey methods? It's on the screen here, actually. Or recruitment, or overall, what was the survey response breakdown by race?
Yeah, thanks for that very helpful question. So we, and you may know this as well if you do online recruitment, it's become very difficult to recruit based off of race and ethnicity, based off of privacy laws, in particular in the United States. And so whereas 5 years ago it was easier to have a more diverse sample, we still had 70% of our sample was white. But given we have such large numbers, we had thousands and thousands of participants of color, which was helpful for statistical analyses that, you know, otherwise wouldn't be able to capture differences by race, ethnicity. It's a non-probability sample. It's, you know, I use some data like from the CDC, the YRBS, it's called Youth Risk Behavior Surveillance Survey, which there's quite a few different kinds across the world, I know. Our data is not weighted or probabilistic. And so I think it could be, the reason why I mentioned that there were some race and ethnicity differences in other models with the same data is that I don't think it's completely an artifact of the data collection and sampling method, but it very well could be. And so I think I answered, so the breakdown by race is 70% white with, I think, 15% African-American. And so low percentages, like I in general, but still with statistical power to be able to maybe detect differences. So I want to caution, we are seeing this a lot in these shade models that where we don't see splits based of identities where you might expect, because clearly there is a difference in seroconversion by race and ethnicity in the US, but maybe not, you know, in this sample in particular.
Okay, look, we don't have any more questions online, and I don't think any in the room, and we're almost at time. So please join me, everyone, in thanking Lisa and Ryan and Donaldson for their presentations.